Hello, everybody. Good afternoon. My name is Agnes Attakai, and I am Program Manager for Native Initiatives over at the Sonoran Center for Excellence in Disabilities within the College of Medicine, Family Community Medicine at the University of Arizona. So welcome to today's webinar, which is Resilience and Mental Wellness. And so before we get started, we do have captions enabled. So we have a captioner. So please take advantage if you need caption services. In addition, we also would like to ask if you have questions to please put your questions in the chat box, and I'll answer those questions at the end of the session. So we'll have some time at the end of today to answer those questions. And we also want to acknowledge that the University of Arizona is also on the land and territories of the Tohono O'odham and Pascua Yaqui nations. And we strive to provide services for tribal communities within the state of Arizona. So that's sort of a modified land acknowledgement in order for us to get started today. And we do have staff in our chat. So if you do run in any challenges during the webinar, please post any challenges that you have in our chat box, and we will address those as promptly as possible. So I'm going to switch back to just presentation mode so you don't see my face, because I do have some images that I would like for you to see when we are doing today's presentation. So again, we shall get started. So for today, we do have 3 learning objectives. One is to learn about the protective factors across 3 domains, which is social, psychological, and cultural and spiritual. We also want to look at some of the documented relationships between resilience factors and health outcomes for American Indian and Alaska Natives. Again, we're just using the federal term in certain parts of the presentation, and I'll switch between American Indian and Alaska Natives to Native people or Indigenous peoples. Third, we'll analyze how interventions can optimize health and well-being in American Indian and Alaskan people. So those are our 3 learning objectives. So I am part of the Circle of Indigenous Empowerment, which is an initiative of the University of Arizona, Sonoran Center for Excellence in Disabilities. And you see on the screen, we have our logo with our name and the logo that has all different symbols for various abilities. We are a central hub of information and resources designed to enhance awareness services and supports that promote quality of life for people with disabilities, specifically connecting connecting services to the tribal nations in Arizona and the urban communities where Native people live. And just as part of the presentation, many times we have people from all over the United States or from other places who come to our webinars. And so I just want to acknowledge that Arizona is a traditional homeland for 22 federally recognized tribes. And actually the word for Arizona comes from the Tohono O'odham Alisonak, which translates as a place of small spring. And you see on the webpage here an image of the state of Arizona with the colored areas, the 22 federally recognized tribes and the reservation area, which makes up probably about 27, so like a quarter of the tribal lands, of the lands in Arizona. And we have various languages spoken: Navajo, Apache, Tohono O'odham, Hopi, Yaqui, Pi, and Yuman. And we have 11 reservations. And so we acknowledge that we work with various communities within the state of Arizona. Now, in terms of American Indian and Alaska Natives, there are currently 547 federally recognized tribes in the United States, and they have a government-to-government relationship with the United States. And we have about 7.4 million American Indians alone or in combination with other races. So we represent about 2 to 5% of the population, depending upon which data set we are looking at. And this particular number comes from the census, and from the U.S. Census Bureau. And there are about 71% of us, meaning the majority of us, live in urban areas. That also means that we move back and forth between urban and tribal areas. And we have about the remainder of the folks live on tribal reservations across the country. And as we work, live, and play in various communities, we also marry into other communities. And so we are becoming a multiracial community. So we have individuals that marry outside of their tribal communities to other tribal members or to other communities. So I myself am Diné. So Diné is Navajo. And I grew up in Arizona in the reservations. And I was also part of the boarding school and also with the urban relocation program. And so my spouse is a non-native person who comes from Chicago. And so our child is, according to the certificate of Indian blood, she is half Navajo and half white, but she considers herself as Navajo. And so in today's presentation, we're focusing on mental wellness. And so we want to start off with just some numbers to let us know the extent of mental wellness or mental health for American Indians. So most of you may know or may not know that there are rates of high psychological distress in American Indian and Alaska Native communities, according to the Centers for Disease Control, according to SAMHSA and other federal agencies who keep track of the numbers of American and Alaska Natives. And in particular, we're looking at American and Alaska Natives reporting serious psychological distress at rates that are 2.5 times higher than the U.S. General population over a month's time. And for those that you work in public health or in health, know that we look at rates of mental health and substance abuse by daily, weekly, and monthly, tri-monthly, quarterly rates to give us a general idea of how prevalent a situation is. So, so in this particular infographic we see on the screen here, this one states that about 2% identify as Native American or Alaskan Native, and 19 to 20% report having a mental illness in the past year. And that's over 827,000 people. That's enough to fill every major baseball stadium on the East Coast twice. And so this gives you the magnitude of the challenges in our communities. But we also have to look at how culture and colonization impacts our communities. And so our community is unique in that we, Indigenous peoples, meaning American Indian Alaskan Natives, were here before Europeans made contact. And we had tribal lands, we had our own culture and customs and language and ways of living and being. But due to contact, we had lands that were stolen. And so colonization ensued to where people took over our lands, and with treaties, lands were exchanged for healthcare and education. But we also need to know that the repercussions of stolen lands, of the trauma from most policies, and also the social climate of racism and racial discrimination are part of the social determinants of health and increase our poor health status. And this is really important to understand because policymakers, educators, people who work in programs need to become aware of the legacies of colonization and ableism to support providing services that are based in indigenous ways of knowing and being and not in Western systems because those systems uh, do not really address the underlying causes of some of the social determinants of health that increase mental health challenges, behavioral health challenges, and other challenges as well. And so part of that, because of the experiences that people have faced, we talk about historical trauma. I am on the board of the National Native American Boarding School Healing Coalition, and we look at the impact of boarding schools on people's well-being. So we document oral stories, we document research and other resources that are out there and house them on our website. And it's really important for us to do that because we need to understand from individuals what their experiences were. So, historical trauma as a field was developed by Maria Yellow Horse Braveheart in her work with veterans, Native American veterans in particular, who came back from conflict and had challenges integrating into their communities. And in working with them, she found out that some of the veterans had suffered a post-traumatic stress disorder and specific to conflict, but also she saw that those who received ceremonies had better adapting skills and reintegrating back into society. And she termed it historical trauma, which is the cumulative emotional and psychological wounding over the lifetime and across generations, emanating from massive group trauma. And in the folks that had challenges of reintegrating, she found out that most of them remember how their communities were impacted by colonization, by land loss, by relatives and ancestors who've gone to boarding schools. Um, and all the trauma impacted to their communities may be through warfare. And she akined it to the experiences of descendants from Holocaust survivors and descendants of those who, the Japanese Americans who were interned um, also. Now, because of trauma, and if trauma is not addressed, it further progresses into historical unresolved grief that people carry. And ceremony and story work really help address those, acknowledge those. And we see through the work of Karina Walters and Anna Bullock, who through research have documented that, in particular, with Anna Bullock's work, that inflammation and stress, high stress situations, create the inflammation that increases a person's risk for diabetes. And so looking at those risk factors and de-stressing and helps to decrease those diabetes rates. And Karina Walters, in her work with her community, looked at going back on the Trail of Tears for the Cherokee and the Creek Nations and reliving that walk and going into prayer and ceremony during that walk and acknowledging the grief and sorrow, and that has helped the community heal. Now, for my particular community of the Diné people, the Navajo people were imprisoned for 4 years in Bosque Redondo, New Mexico, after a slash and burn policy to remove Navajo people from the homelands, and they were forced to walk 8 miles, thousands of miles, and 2,000 people died of starvation and sickness. And we were told growing up that we were not to talk about it. It was a time of grief and sorrow, welti. And so people didn't talk about it, but now people are discussing it, are talking about it, and helping to address some of the sorrow and acknowledge what our ancestors went through to continue on our communities. And the only way that the Dene people were able to come back was through the Treaty of 1868, which which established the Navajo Reservation in Arizona, but also mandated that our Navajo young people would go on to mission schools and go into education. So that started the process of children being taken to mission schools and boarding schools and started another process of grief. So if you're interested, there's a link to the Long Walk Tears of the Navajo that I'll post later on in the chat. And because of those experiences of trauma through land loss, through colonization, through boarding school area, we talk about what trauma is. Trauma can be one-time events, just getting an accident, death of someone close, or loss of relationships. And those, folks are able to may or may not address, but usually is not recurrent. Ongoing relentless stress is where we have individuals or societies that are faced with continual stress, whether it's poverty, domestic violence, social isolation. And we saw in the COVID times, the pandemic brought on stress, chronic illnesses, oppression, politics. So those continued stress can actually change our way that our bodies um, respond to continual stress or later stress of different sorts, but also the way that our body is able to process it through brains or through our brain, our responses to it. And also the way that our physical body responds to it. And so Anna Bullock in her work looked at how inflammation caused by stress increases diabetes risk, but also increases other risks such as high blood pressure, cholesterol, and so forth. And for young children who go through this, you had reverse childhood experiences that really create stress at a very young age. And it really impacts future generations because they say that our grandmothers have carried the genes for their grandchildren already in their ovaries. And so if they have experienced stress, the stress changes reactions and also cells very early on. And so that impacts future generations. Okay. But we also have to look at now what is considered the social determinants of mental health. And this is based off of a book called The Social Determinants of Mental Health. And previously, mental health was seen as more of a healthcare issue. It was individual treatment, and some of the treatments were pretty archaic in terms of changing the way we respond to stress. And many times it required institutionalization, being removed from community, going through shock therapy, going through medical therapy, and those really did not work. And so this book in particular looked at what other factors really impact our mental health. And so, U.S. societal problems, social determinants of health really impact us. We talked about the adverse childhood experiences, long-term discrimination that people feel, the policies that impacted communities, preventing them from integrating into society, like African American communities, slavery, all that really impacts our mental health. And exposure to violence as well. But we also have to look at the socioeconomic status and opportunities for accruing wealth. Because our communities did not get the adequate education. And many times, folks have gone to boarding school. If you are aware of what the boarding schools were, they were pretty much training grounds for Indigenous, Native American Indian, Alaska Native children to learn vocational skills so that once they graduate out of the program and are released back to the community, they are usually assigned to be servants in white households, that they are sent to farms to farm or to sent factories to do vocational job work. And so it was not so much the college track, as you say, but it was basically to help out in the economic machinery of the United States. And because of that, many times a lot of people are unemployed or have job insecurity nowadays. Poverty in also increases inequalities, and many times because of federal policies, we live in areas where we may not feel safe, and so those cause stress and increases mental health stress as well. But we also need to look also the basic needs of housing, food, and transportation. So housing, food, instability, and security really increases stress. Poor access to transportation, poor access to healthcare. Um, but we also need to look at the physical environment of where we live. In the built environment, as we see in some of our communities where we are resource poor, they usually place factories and businesses that pollute, especially in tribal communities. We have a lot of communities that are impacted by mining companies who come in and do extractive industries and pollute the environment. Up in Navajo Nation in Dene, we were impacted by uranium mining, where a lot of our men went into the mines without any kind of protective equipment. And so we had high rates of cancer and lung cancer in particular, and respiratory diseases because of that, because there was no protections. But they also brought uranium on their clothing, the dust, the yellow cake. It was on their clothing, and so when they went home and their spouses or kin would wash their clothes, the family was exposed to the dust there, and there were no precautions on using uranium. So many times folks brought back uranium as well and were made it part of their household. Even today, we see coal mining as an industry coming back. We see, again, some of these data centers now going into communities. And you know that most of the airports are also located in resource poor areas, and so people are impacted by the pollution from those communities. And there's a link to particular the article that talks about the social determinants of mental health. And we can't talk about American Indian Health without talking also about Indian Health Service. And Indian Health Service was created in 1955 to provide health care to American Indians and Alaskan Natives who were enrolled member and part of federally recognized tribes. And it provides primary care, dental care, vision, mental and behavioral health care, pharmacy services, but those are vary by region. And so you see the image to the right is the Indian Health Service area. There's 12 service areas. So in Arizona, we are part of the Phoenix service area, so that we have 3 different states. So we are our population has a lot of American Indian folks. So we do get monies that are given to Indian Health Service units to help run clinics, that help run hospitals, that help run some of the preventive programs in mental and behavioral health services. However, Indian Health Service is under the U.S. Department of Health and Human Services, and so their budget really depends upon congressional appropriations. And at this moment, it's usually about 60% of what is needed, so it's under-resourced, which means that services are rationed, and they have a priority system of services that are essential, and that usually is cancer, diabetes care, and many times, depending upon the service unit, it may be substance abuse and mental health. And so the priorities are different for each of the different regions. And it is, again, a federal program. So But that has changed over the years with the Indian Self-Determination Act in 1970 as a federal policy that was initiated and established because Indian Health Service, even though they provide primary care, was not providing effective care, and it was a medical model. So Native advocates advocated for funding to go directly to tribal nations to help manage their own tribal programs. And so the tribal nations were able to contract with the U.S. federal government to be able to run those facilities. And so, therefore, you have services such as here in Arizona with the Gila River Indian community who run their own hospital, who run their own diabetes programs, mental health and wellness programs, versus in the urban area, the Phoenix Indian Medical Center, which provides primary care. And so it creates many times a very complex network to where people have to navigate and access resources and services. And that can be challenging for someone who seeks out mental health services because if their Indian Health Service does not provide mental health and behavioral health services located nearby, it's not integrated into the system, then the individual has to be referred out to another entity who can provide those services. And usually those services are by non-native providers. And so, for instance, growing up on Navajo, my father, who was in the Korean War, came back with post-traumatic stress syndrome. And he had nightmares and he had a lot of different challenges, really highly stressed. He had highly reactive ways of dealing with stress. He was always on a hyper state. And because he could not sleep, because he could not rest, he started drinking to help alleviate those nightmares, to be able to sleep. And the drinking just became more and more drinking to the point where he would pass out. And so, as a veteran who lived in California at the time, when we were a part of the urban Indian community, there was no resources for him to utilize during that time in California because there was really not enough urban services for urban folks like us. But when he moved back to Arizona and he retired and he lived on the Navajo reservation, there were no veteran services. The closest thing he could go to was the Veterans Administration in Prescott, which was for him a 2.5 hour drive. He did not drive. There was no veteran services, so he could not receive any services for his anxiety, for his depression, and so he just continued to drink. And unfortunately, he passed on because of those conditions. And so that's some of the challenges that people face when they're trying to access mental health services in communities in tribal nations. Now, when we talk about wellness overall, we also need to think about resilience factors. What are some things that are part of creating that healthy tribal community? And I like this model. This is from the Vitalist Health Foundation. It's called the Tribal Wheel, that was created back in 2019 between the Vitalist Foundation, which is here in Arizona. It's a foundation that looks at underlying health equity issues, and they work with the Intertribal Council of Arizona, which is an agency that represents all the 21 tribal communities in Arizona on a lot of healthcare issues, a lot of social issues. And so they end up being the agency that receives some funding that smaller tribal communities are unable to access, and they coordinate a lot of services in terms of like Indian aging, diabetes. And so they worked on developing the healthy tribal community model here. And the four principles are, again, looking at beliefs and spirituality. So that will be the lighter turquoise color. Resilience in ways of life, which is the greener color, and that one includes community, includes access to care, access to food, then and and we also look at self-determination, which is the darker turquoise color of how can we as communities be able to run our programs and also advocate on our communities, because we have 574 tribal communities in the United States, and each one has different systems of beliefs and culture and ways of being and knowing. And we also need to look at tribal governments and sovereignty, because we have that unique relationship with the United States, that we're able to operate our own communities. And so all those really work together to look at creating a healthy community that's based on our spiritual, emotional, physical, and mental needs, that's focused on the family and the community and the way we're able to access all these and continue our way of life. And this is how we view a healthy community. And most of the ways that we look at mental health um, and health in general is more of a medical model that focuses on the individual. So a lot of individualized treatment, individualized services, but in communities, it's focusing on the community and what makes the community healthy, which is really a different way of looking at it, which is many times different than public health models like the social ecological model and all and other health belief models that focus really on the individual. We focus on the community, sort of called the indigenous determinants of health, which was termed by several other researchers, including Dr. Don Orn. And as I said before, the Western medicalized approaches are really not effective, especially for our communities, the way that we understand, the way that we are, our indigenous ways of knowing and being. And because of colonization and the challenges and the high stresses that we faced, a lot of our people, depending on the communities you go to, have high rates of suicide. And many times, if we look at the general numbers, it's more than other racial or ethnic groups. Suicide is the second leading cause of death among American and Alaska Native adolescents, our young people, with a suicide rate of about 18.95, say 19% per 100,000, which is 170 times more than non-Hispanic white adolescents. And then we also look at data from the 2021 U.S. Census for Disease Control and Prevention Youth Behavioral Risk Survey. And that is a survey that's then again looks at risk factors among various different populations, and we have a specific one that pulls out numbers for American and Alaska Natives. And in that particular survey, they found out that 20% of American Indian and Alaska Native youth had considered attempting suicide, and it usually were majority of with girls. So girls considered, but young men were the ones that completed more often. So 22% had planned suicide, 16 attempted, and 1% were injured due to suicide attempts. So looking at these numbers, we also have to consider that these are general numbers. So what I'd like to state is that these are numbers, surveys that are done with communities either by phone or by internet or looking at data from cases and so forth. So it's again pulling numbers across the U.S. and compiling a number that assumes and reflects American Indian people. But again, it's an aggregate of a lot of different numbers, and it reflects American Indian Alaska Native people in general. It does not focus on regional and community numbers, and so those numbers may be different. We do have Indigenous American Indian communities where suicide is not an issue. So we have to take that with a grain of salt. These are just estimates that give us numbers to think about how a problem is, but just be cautious and aware it's not reflective of every single community. And we don't want it to seem as though there's so many issues in the community and really reflect poorly on people in general. Okay. But we have to think about mental health as a collective challenge in our communities. It's not individual. So it is influence, again, when we talk about the social determinants of health, mental health is influenced by social, cultural, and historical contexts in American Indian communities. And so I like this particular model from the National Inuit Suicide Prevention Strategy. And there's a link to this particular project with their model that talks about health, but also looks at all the social determinants of health that that is important really to consider. Culture and language, livelihoods, the quality of childhood development, availability of the health services. Again, we're looking at indigenous determinants of health, things in our environment that help or do not help in our community. But in this case, we're looking at health things. And again, this is also another model from the University of Alaska Fairbanks. In particular, they developed a toolkit that looked at working with rural Alaska people. And in this particular model, they looked at some of the stressors that tribal and community members face in their personal lives on a daily basis. And Alaska, Alaska Native peoples particularly face a lot of geographic barriers because their community is only accessible by aircraft or boat in the majority part of the state, and there are a lack of basic services such as running water and access to food and so forth. So in this particular model, again, we're looking at some of the challenges their particular communities face, and that everything costs more. Their environment really impacts the way of life they live. They depend, their subsistence hunters that depend upon whale and seal. So the environment really impacts the ability to be able to harvest and provide food. But also, if it's too hot, then there's not enough snow, that there's flooding, and whole communities have actually had to relocate because of the weather, and that has an impact on people. And there's also personal burdens of trauma. A lot of Alaska Native people were also forced to go to boarding schools, and many times were moved from Alaska all the way to Pennsylvania or to the lower 50 states, thousands of miles away from home. And very few community structures, because there's internet and phone, housing, roads, and so forth, are really challenges up there. And this really impacts the mental health of people. But we also have to look at what protects us. Family reduces depression, anxiety, having supportive adult relationships, and community support really buffers and affects the effect of childhood adversity and improves wellness. And this is where our kin network comes in. Our community and family takes care of each other in an event something were to happen. So I myself growing up, because of the childhood I faced with a father who suffered from post-traumatic stress syndrome and drank a lot and uh, and with living in California where it was really cost prohibitive, I was sent to boarding school for a couple of years, and after that I lived with family, aunts and uncles, and so they were the reason why I had a safer home life with a larger family versus being isolated and living in California. There's also psychological resilience, ways that we are able to help our own selves in addressing some of the challenges. And so that's just where ceremonies really came in to help relieve depression and anxiety and lower that stress. And I'll talk about that in some of the programs I want to focus on later on. And then we also had how culture really strengthens our identity and self-esteem and improves our mental health and healthy behaviors, and spirituality really supports prevention and recovery. So a lot of our prevention, recovery, and mental health programs now, due to the fact that tribal communities are able to use their own monies to develop these programs, incorporate a lot of these practices that help communities, such as sweat lodges, drumming, singing, arts-based activities. And this is an example. This is the Walking the Good Road of Life, is a curriculum that focuses on culture and addresses multiple ways of well-being that promotes resilience. And it's a training program where they do 1 day train a trainer and 3 days of working with students. And they completed an evaluation, public health evaluation, this particular program, and found that it does lead to well-being, increases generational knowledge and positive behaviors. And so again, some of the aspects we've talked about is, looking at the collective healing of the community, addressing what has happened to us historically. How do we build resilience in our community, in our villages? How relationships are important, knowing our clans and who we are, and ways of being well. And so this is one example of a program that's really doing well in increasing resilience among Native youth in general. And this is also another one through First Nations and their adoption of the Zero Suicide Toolkit for Indian Country. As we know, in working in public health and health, there's always evidence-based interventions that are developed, considered the gold standard, where programs are created and evaluated and are seen as effective. And many times are promoted and promoted to be adopted in other communities who are facing similar challenges. But a lot of those programs are developed in urban areas with mostly white, stable socioeconomic communities. And adapting those type of programs may not be a good fit for tribal communities, especially in rural communities, especially in communities where you are not depending so much on a nuclear family, but an extended family network. So in this one, they modified this particular model, and again, family and tribe and community are important in engaging individuals in a collaborative safety plan that celebrates traditional healing practices are important. And mental health is improved through policies and procedures and data that are culturally responsive to individuals and families. And again, treating individuals using treatments that are respectful of the norms of the community, and also training staff to understand the unique physical and emotional spiritual needs of Indigenous people. So this is also another a program that has been adapted and that's been really effective. And there's a link to this particular toolkit there. So we have to think about how Indigenous healing practices really are important for us to develop. And this is a particular model from the Aboriginal peoples. And in this particular model, we see all those cultural activities that help us keep well as a community. We have elders in the community. Many tribal communities use the medicine wheel, many different colors of the medicine wheel. Generally, it's, people have used white, yellow, red, and black. For Navajo people, it's actually not red, but blue. So ours is white, yellow, blue, and black. So it's different colors. But we see that we have activities such as sweat, singing, drumming, teachings, gatherings, and all these that help maintain a healthy community. So this is definitely different than a Western treatment model where it focuses just on the individual. And some of the treatment that's currently being used, such as polyvagal theory, talking about our fight responses, how our body becomes dysregulated, and how we need to re-regulate it during different methods. Again, it's on an individual level. But before we had that, we had ceremony that helped us regulate these particular flight and fight responses. And in these ceremonies, it included community. So it was not an individual effort. Before we had like somatic experiencing, we had dance, shaking, and sweating. So somatic is meaning that you do physical activities that help you ground, like focused breathing, doing body scans, muscle relaxations, sensory engagement and movement, and those um, as an individual level. But in our communities, we've done sweats, and sweats are usually done in community groups by gender and involve a lot of people in that process. Community singing and dancing through powwows or ceremonial dances and ceremonial singings are some of those experiences that we've had. Before narrative therapy. So, narrative therapy is used in treatment, where again we think about um, different realities, we share stories, how that's impacted us. It helps us make sense of experiences, but then it's an individualized way to address it. But in our communities, we had story work. We had communities where traditionally people told the stories that shared with us how people face challenges, and how it helps gives us ideas and hopes that that we can also face the same thing. And during our traditional healing, where stories are told in traditional healing, we go through that process as along with the people within those stories. Say, in particular, as Navajoists in our traditional healing stories, we talk about our origin stories and all of our deities and spiritual beings who've been there and what they've done. And so in our traditional healing, they retell those stories, but you as a person being healed are along in that process, in that story. So you're embedded in the story and you're facing those same challenges, but the beings are there to help you to recover. And so you're part of that process. So again, community work is the story work is community work. And I like to close and talk about resilience and mental wellness in the community and what it looks like. We've seen all the different models of the circles. You know, we looked at the individual medical model and the community holistic model. And so, but we're also looking at models where it's more personalized, individualized to the community. So we see here the holistic integrated cultural model in the Northwest area, where we see the canoe and how the canoe is central to this particular community and how it's part of their healing and part of providing care. And so in this particular graphic image, they're able to utilize this specific image of the canoe and the people in there. Remember, it's not just one person, it's people in there all helping to navigate using the paddles, and each of the paddles have different words of health, of community, and different geographic systems represent certain things like water and paddles, rocks meaning anti-racism. The current represents this. People in the canoe represent capacity, and riverbanks represent equity. So we need to look at what our communities see as resilience and how we see mental health and how we incorporate the community in our treatment, in our ways that we become healthy and create our own models of wellness and safety. So again, if you like further information, if you like for me to share the PowerPoint slides that have my notes, and then have the links to the resources, it's a fairly large file, but I can send it to you by email if you wish. And you can just share your email in the chat and we will go from there. We do have a couple of notices in chat. There's tribal vocational rehabilitation programs in nations, and so there's a link there. There's also a link to Indians in Sobriety hosting a 39th annual recovery campout at Blue Water Lake Slate Park in New Mexico. So more information about that. Um, any kind of questions? So we have some time for questions, and I'll stop sharing my screen and I'll put my video, so you'll see my face now. So pretty much. Okay. Okay. Anyone have any questions or any thoughts? I'm not the expert. I'm just have worked in the field for a bit, and so just sharing with you some of the things that I have experienced. Okay, let's go to chat. So just a personal reflection on my part, as I talked about a little bit growing up and with my father and his challenges and growing up, experiencing a lot of the trauma that I faced growing up, living in that environment. It's taken me a while to really address those, and I remember it really impacted me the death of my brother. My brother had raised me as a young child, and he had pancreatic cancer back in 2018, and fairly quickly, and he went fairly quickly. It was within less than a week after he was diagnosed, and I remember he spent most of his life in California, and when he was went into the emergency room, and we knew that he wanted to go home back to Navajo. We made arrangements to be able to bring him back home, but when I got there, he crashed and he died that morning. And to me, that was one of the biggest challenges that I faced. And and it took me a while to really think about what that meant. And so I actually went to therapy, and I could not really understand what some of the sessions and talking about it, what that was supposed to help me out with. And so I stopped going to therapy. It was a white Caucasian lady, and try to tell her all the stuff that I went through, but it was just so much that I think it was overwhelming her with all the stuff that has happened in our communities and everything. Um, and she just wants me to help address and focus on a specific aspect, and it really didn't help me out, and so I stopped going. But then I started going to a group where we were drumming, where we would talk about some of the challenges, and I knew that the ladies who I was part of the drumming group with went through the same challenges and understood, so I didn't have to explain myself constantly and explain to someone who didn't know about being a Native person and some of the challenges that we had. So it made it more easy that I was finding comfort in sisterhood, that I was using drumming to reconnect, that I started talking more about some of the challenges I faced, and it was confirmed. And other community members shared with me some of the ways that they were able to deal with some of the stresses, some of the bouts of depression, anxiety, and that helped. And so I think it's really important to really think about how Native people view as healing more in a community setting versus in an individual setting. So from then on, I started working more closely to what it looks like and using more art-based activities. And so I do a lot of art-based activities with young people, and that seems to be the way to get them to start talking about some of the challenges that they're facing, and not so much in a therapeutic setting. So anyway, okay. So let me see. We do have a question says from Maria says, what community level protective factors have you seen make the biggest difference in reducing suicide risk? We have seen, especially in Arizona, if there are communities who have had high suicide rates, and they've actually had gatekeepers, as is the only term I can think of, but you would think them as community members and community role models of people who were trained to know the signs and symptoms and who were on call whenever they heard from somebody else that a young person was facing challenges, and they would go out there and just sit with the young person and just talk and share and just be in presence. And so I think that is one of the ways that community level protective factors, meaning that the whole community is out there um, helping to embrace young people and people in need, because when you're facing such an issue, it becomes lonely. You feel like you're the only one. But if you have someone there who's just sitting by you, maybe not saying anything, but there, you don't feel as lonely. And then eventually you're able to open up and start addressing some of the challenges that you're facing. So again, it's a community-wide effort of ensuring that, people are not alone, that you are there to help them out. So, there are other people who've written about it, and so if you are interested in particular, I can send those programs to you specifically. Um, I can share that to you. Let's see. And again, the American Disability Law Center is this individuals with mental health who are currently incarcerated. So that's also another good resource there. Because, unfortunately, in our communities, we have some of the highest rates of incarceration, and that is due to many factors, and that's because we live on federal land. So a lot of our crimes are considered federal crimes in U.S. society many times, and there are many times in U.S. society are not considered federal crimes. And so when a Native person commits a crime that's considered a federal crime, they go through the federal court system, which has higher sentencing and higher rates of being incarcerated in federal prison, not jails, in federal prison, which requires longer sentences. So we do have high rates of incarceration, unfortunately. And what was interesting is that sometimes for folks who do go into the penal system, that it's the first time they do get diagnosed with the mental health or maybe learning disability, because that's the first time they're able to access healthcare that they're seeing. And if they follow a treatment program in prison, that they're able to, get treatment and get medication. But once they get out, there is no support system for people. So when you're released from prison, you're released. And so there's no support system for folks. And so that's why there's high recidivism rates because of that. So, let's see. Okay. So thank you all very much. It is now 12:04 Arizona time. So time for lunch. Thank you, everybody.